So welcome to the Enhancing Clinical Practice and Outcomes stream of the SNOMED CT Expo 2022. My name is Sarah Warren and I'm a terminologist here at SNOMED International, and I will be moderating today's session. All questions will be answered at the conclusion of the presentation. For online attendees, please use the Q&A box to type in your questions to the presenter. For on-site attendees, we have a microphone, so just pop your hand up and we'll come round to you. So I'm now pleased to introduce Marte Rime Bø from the Norwegian Directorate of e-Health, who will be presenting standardized care plans in Norway using SNOMED CT, knowledge support and decision support for clinical nurses across levels of healthcare. So Marte, over to you.
Thank you, Sarah, and thank you for inviting me to the SNOMED Expo and the beautiful Lisbon. I've had the pleasure of staying here for a few days now and seeing what this wonderful town has to offer. Like Sarah said, my name is Marte. I'm a clinical nurse and I'm a nerd. And I have a master's degree in health informatics. Since 2020, I've worked as a senior advisor at the Directorate of e-Health of Norway in the terminology unit and the Norwegian NRC. I have previous experience working with standardized care plans, both as a clinical nurse at the hospital and as an advisor at the Southeast Health Region of Norway. And I'm going to talk more about the health regions. Was there a trick to this, Terence? Yeah, turn it off and on again. Use the other trick. Oh, waving at Terence is the other trick. Yeah. I know what it is. 2 seconds. Ah, okay. Glad I didn't jump 10 because I did click 10 times. Okay. I will briefly talk about the Norwegian healthcare system as a background for the work with standardized care plans. And I'll also talk a little bit about the nursing process that we use making the care plans and the situation before and after having standardized care plans in the EHR, and now how we use SNOMED CT in the care plans. Okay, so determined quick. Determined quick. Norway has a national healthcare system, and the state is responsible to provide good and necessary healthcare services to everyone. In 2002, there was a hospital reform where the government took over the responsibility for running all the hospitals in the country. Hospitals and services after the reform was organized into 4 health regions, and the acquisition of EHR happens on a regional level. So you see, Norway is the blue thingy over there, and it's even partitioned in the different health regions. So after the reform, 3 out of 4 regions chose the same EHR that had a module for care plans. The 4th region starts using a new EHR at the hospitals this fall, which also has a module for care plans. So we are getting ahead. That is the gray one in the middle. In that region, the primary healthcare already uses standardized care plans. So it'll be cool to get the hospitals up and running on that as well. We also have a patient safety program in Norway that started in 2011 as a national initiative to reduce healthcare acquired complications. This by ensuring best practice, and several of the national standardized care plans comes from this initiative. Some of you in the room might be nurses. I see some nodding here, that's good. So you are familiar with, with the nursing process, and that is just a modified scientific method. It is a circular process as the patient's condition may alter quickly. So I'm just gonna take a little look. You still hear me? So you do an assessment of the patient's situation, and then you identify a diagnosis. And I'm not talking about medical diagnosis from ICD-10 and stuff like that. I'm talking about nursing diagnosis. And I'm going to give you some examples for that today as well. And then you identify what outcomes you want for this patient, and you find what relative interventions you need to do with this patient to achieve that outcome. So you implement the plan, and you have to do an evaluation and an adjustment, because the patients, like I said, the condition may alter quickly, and then you're around again. So this is an ongoing process when treating patients. In addition to the nursing process, all of the care plans are evidence-based. With this, we mean to make decisions based on professional experience, critical judgment, and knowledge about the patient needs. The national standardized care plans are being revised every 3 years in Norway. So, the old-fashioned paper-based medical records, they did not support coherence of information needed to administer medical help, as the information was scattered all around the different medical notes. So many nurses and other health professionals spent a lot of their time trying to find the information they needed to give appropriate care. All in all, this did not support the treatment process from beginning to end, and allowing the different information elements to be used together as a whole. So there was a need of gathering this information into a tool that was easily acceptable to nurses when we switched from patient-based documentation to electronic health records. And the nurses in Norway were the first group of medical professionals utilizing structured documentation in the EHR. Yeah. So before we had EHRs and before we had this tool that I'm going to talk about, spoiler, it's the care plans. We did do assessments, but they were rarely used for making plans. And there was a few regional tools, there was some local tools, but there weren't any national tools for making this assessment and finding out the patient's resources and the patient's needs. The current issues, like I said, was scattered around the medical record in free text of varying quality, and there were very rarely specific goals for nursing. The interventions were often ambiguous or at a very general level. The reports from the nursing shifts were free text. There was a lot of without remark. I don't know if you have that sort of thing in other countries as well. Low quality, worrying quality, and results were documented as free text, if at all. This led to failing information flow, problems with getting a good overview of the patient needs. We didn't have a standard for documentation, and also there was a lack of knowledge and decision support. So the 3 out of the 4 health regions in Norway that started to use the same EHRs in the mid-noughties had a module for care plans. That system was based on the NIC-NANDA terminology, and most of the different hospitals started local initiatives for standardized care plans. The care plans was based on diagnosis or specific patient groups, specific treatments, and after a while, these plans were converted to ICNP. Now, as ICNP has become a part of SNOMED, and there has been done international equivalency between the two, the plans are now using SNOMED CT. So all of the around 2,000 concepts that are in the international nursing ref set in SNOMED CT has been translated to Norwegian, and we're also translating more concepts as needed. We have a national committee that works with the standardized care plans, and then now can choose concepts from all over SNOMED CT and not only for the ICNP ref set. The implementation of standardized care plans was done in stages. They started with the biggest health region in Norway, the Southeast regions, And later, hospitals could borrow care plans from similar wards from the first hospitals. And this sort of started up a more or less spontaneous cooperation between the hospitals. We visited each other, we gave each other the care plans and discussed how we worked with them. And this cooperation was later used for a large-scale national collaboration for care plans, where the Norwegian Nurses Association was the initiator. Standardized care plans are now, and has been for several years, been the primary documentation for nurses in the southeast region of Norway. And the hospitals in the other 3 regions are on the verge of implementing the care plans in their EHRs as well. So today we have a national editorial group with representatives from all of the 4 different health regions, the Norwegian Nurses Association, the University of Agder, and the Norwegian Directorate of e-Health. We had a meeting last week in Trondheim, and this is a picture from that meeting. It's very updated. The editorial group collaborate on standardizing care plans on a national level and to edit them, like I said, every 3 years. And I used to actually be a part of this group representing the Southeast Health region before I switched jobs, so I'm very familiar with their work. All of the standardized care plans are based on principles of best practice and current research, and about a dozen of the national standardized care plans comes from the National Patient Safety Initiative. So we now have 40 national care plans, and we have 200 regional care plans that are being reviewed for national status. It's the same group that's reviewing all of the local plans. So far, we only have representatives from specialist care in the editorial group, but we are trying to recruit representatives from primary care as well, as the primary healthcare also uses some of the national care plans and their own local standardized care plans. So the goal is to use the same plans across all of the levels of healthcare to ensure patients the same quality of care wherever they are. And I have to brag about these people because several of the members of the national editorial group has taken the foundation course. Some of them has also taken the Authoring 1 course. And Beate and I, we have held several courses on how to search using the SNOMED browser. We had one course 3 weeks ago with about 100 attendants from the Southeast region to learn how to find relevant SNOMED CT concepts by themselves. And we can also help them if they have questions. So it's really cool now that the National Editorial Group has become competent at using the SNOMED CT browser, and they're finding a lot of good SNOMED CT concept they want to use in the care plans. So they're already taking these SNOMED concepts into their plans, and they're making a list of new concepts that they want to have included into the national nursing ref set. So they are gathering them up and sending them to the ICN. And these are, of course, concepts that we prioritize translating into Norwegian, because we're not done with translating the whole SNOMED CT yet. It's quite big. So the care plan starts, like I said, with a diagnosis based on the assessment and the patient's situation. The diagnosis are mostly found in the disorder and the finding hierarchy. And I was also corrected yesterday that we also use the situation hierarchy for this. So the example here is does not fall. No, sorry, at risk for falls. That is one of the nursing diagnoses, as I said. So it's not a disorder as such, but it's a finding. And when we have established the diagnosis, we specify the outcomes we want for these patients, and the outcomes are found in the finding and the situation hierarchies. For instance, does not fall. That was one. To all outcomes, we connect interventions that are needed to achieve the chosen outcomes, and the interventions are found in the procedure and the regime therapy hierarchies. For instance, provision of mobility device. Did I remember that correct? Yeah, good. I didn't wait then, yes. So what we get with standardized care plan is knowledge support and decision support. This as a predefined plan for a specific patient group or diagnosis with defined outcomes, where each of the outcomes have a set of interventions that help work towards that outcome. I know I'm repeating myself, but this is a very important part of why we use the standardized care plans. So when you get in a patient with one or more issues there is a plan for, you can choose the relevant outcomes for that specific patient, and then choose out of the suggested interventions to set up an individual care plan for that patient specifically. You can even combine plans if there are comorbidity, or look in a different plan for a specific diagnosis or a specific outcome, and then you get suggestions for what kind of interventions you need to do. So the assessment is now used as the basis for the personal care plan that you make with a standardized care plan as a template, and current issues are documented as diagnosis in the care plan. And the nurses get knowledge support with the suggested outcomes. Interventions are then suggested based on the diagnosis and outcome, and that provides the decision support. Documentation happens in the care plan. Oh, it worked, sorry. With adding or archiving issues, which means there are very little free text. So you only use free text if you have some comments about deviation from the care plan. All of the documentation just happens in the care plan other than that. And the results are documented in coherence with either the diagnosis or the outcome in the care plan. And I say either or there because a couple of hospitals or a couple of regions have chosen to solve that differently in their implementation. I didn't go to, The results of using the care plans in general and using the standardized care plans as templates are easier documentation, better and clearer language. They're very simple and effective to use. There's easier access to updated practices. And you get a better overview of the patient's resources and risks, easier access to decision support, and quality control in the choice of relevant interventions. And these results were found in a study done in the county of Vestfold in 2017, based on the use of 5 of the national care plans from the National Patient Safety Program. That was risk for fall, risk of malnutrition, risk of pressure ulcer, risk of urinary tract infection, and reduced ability to handle medication. We have made a snowstorm terminology server that includes all versions of SNOMED CT, local languages and extensions. And we have put 34 of the national standardized care plans in it as ref sets. Now I'm starting to just teasing you about what Beat is going to talk about tomorrow. And we have made a demo to show how the care plans can look like in an EHR. So this is just a proof of concept and a demo. But it's to show you how you can have this information lying in Snowstorm and showing it in a different setting. We see a great potential benefit of having the plans as reference in Snowstorm. So I have an example here. I think I've sticked to at risk of falls. Nodding, good. So that's the national standardized care plans for fall prevention. So I have selected at risk of falls as a diagnosis. And as you can see, I get 3 suggested outcomes for that diagnosis. Disease frequency of fall, does not fall, and and no injury due to falls. So you can see that we have 2 findings and a situation. I selected does not fall, and I get suggested interventions to choose from. You can see those in the boxes. There are more, but I couldn't fit it into the screenshot. And by crossing off this and saving, I can make a personalized care plan from a patient, just seeing how it is in practice. So having these plans and this information in StoreStorm can make them easily available in any given language, given that the concepts are translated, to anyone who wants to use them. And if you want to know more about this, Beate is talking about this at her presentation tomorrow at 1:30 in the terminology leading practices session. And we have a laptop with us, so we can also show you guys today or tomorrow if you want to see how it looks. So thank you very much for listening.
Thank you very much. So Marte will now take questions. We've got about 5 minutes for questions. If you're in the room, we've got a microphone that we can bring to you. Thank you.
Nice presentation. You're talking quite much about the standardization part of it. And of course, SNOMED CT is great for terminology and ontology standardization. But do you know other standards for what to document and how to structure things?
I'm not sure. This is the committee that makes the plans sort of decides what sort of information we need, both to treat the patient and to document about the patient. But I'm not sure if that was what you asked.
It was more like if you're using formal standards for that, or if the only formal standard you're using is SNOMED CT.
The only formal standard we're using are SNOMED CT, apart from the residual ICNP stuff that's in there. Yeah.
Thank you. Any other questions in the room? Yep.
In the back.
You permit to choose some concepts. So did you add some free text to the concept? Did you permit also to add a concept and a free text to precise the concept, for example? That
is up to the EHR, but I know that both the bigger one, DIPS, and EPIC, which they are taking, that they're starting to use in the middle part of Norway, allows for free text specification or free text comments on the different both interventions and outcomes. Say that you want to have body weight within normal limits. You can also specify that in free text connected to that goal, so that when you document against that goal, you know what the goal is specifically, not just within normal limits, which can be a bit ambiguous.
Thank you. And we've got a couple of questions that have come in online. We'll just go through those. So this is excellent work. What is the information model that is driving the user interface, or will this be discussed in tomorrow's presentation?
That will be discussed in tomorrow's presentation. So that's the brains of the operation. She's going to be talking about that.
Great, thank you. And another one from online is great work. Is there a link to the demo? Our CNIO would be very interested in this and ties in with our local discussions in the UK.
There is a link to the demo.
Perfect.
Yes, and we can publish that. It's also in one of Beate's slides tomorrow, but you know, we don't want to show everything too fast, but yeah, I don't think it would be a problem if people are a bit familiar with the demo.
Excellent. Yeah. And another one's just come through. Great presentation. Hi from NHS Scotland. I may have missed this, but could you clarify what interface is used for the care plans? Is that another one for tomorrow's presentation, or?
That is for tomorrow.
Yeah.
No, the thing is, this is sort of the baseline for Beate's presentation and the sort of the conundrum we are in Norway, because these care plans are now distributed as Word documents and as Excel spreadsheets, and trying to find a better way of storing them and distributing them is sort of what we have been working on. So I would, of course, prefer if Beate was straight after me today, but you just have to hold your horses until tomorrow.
Super. Thank you. And just before we end, any more questions in the room at all? Yeah, we've got one more.
Thank you very much. I would like to ask you whether if you think that some of those personalized instances of these plans have a use case for sharing between those regions? I mean, some patients, they actually move from one region to another.
Yes.
And then it could maybe be useful to be able to reuse those already scheduled plans.
Yeah, we're hoping to be able to do that in Norway. Also between the different levels of healthcare, when you are discharged from the hospital and someone else is taking care of you, that would be interesting. And also if you're going to a different region. I don't think there's a solution for that in DIPS just yet, crossing the regions, but what we have done so far is just to print them out and transferring them like as paper and then set up a new plan to come. And that's not a good solution. So hopefully.
So if I suggested to you that you should use fire to do that, what would be your, what would you like? Would you like that, or do you think that?
I like that, yeah. So, but that's in the future concepts. But thank you very much.
Super. I think we've come to the end of this session, so we'll conclude it there. Thank you again, Marte. And online delegates can join another session through the event lobby. Thank you, everyone.